and the diagnosis of ARDS is made by development of hypoxemia approximately 24 hours after resuscitation from shock and either trauma or sepsis in the absence of the other causes. Just as we can see in the following pictures, the chest X-ray or CT usually shows a diffuse infiltrator, and this is a flow chart of ARDS development. And from the flow chart, we can see that acute respiratory distress syndrome typically follows shock and either trauma or sepsis, which activate coagulation and inflammation in the injured or infected tissues, and release coagulative and inflammatory mediators into the circulation. And the lungs bear the brunt of the insult from any process that involves the non-splenic portions of the body, because they receive all the venous blood that returns to the heart, and because they contain the first microvascular encountered by the mediators. And the mediators disrupt the microvascular endothelium and the plasma extravasas into the interstitium and alveoli, and the resultant pulmonary edema impairs both ventilation and oxygenation. The embolism to the lungs impair perfusion. So all these changes will eventually lead to hypoxemia and hypercapnia. And it must be noted that ARDS is an acute severe injury to both lungs. Patients with ARDS experience severe shortness of breath and often require mechanical ventilation because of respiratory failure. The mechanical ventilation is an important life support. And sometimes ARDS and acute lung injury are easily confused. Which is the cause, or are they two stages of the same disease? And at present, scholars have a relatively unified view, and ARDS is one of the causes of acute lung injury, while ARDS is a severe stage of acute lung injury. They are two different stages of the same disease. Meanwhile, it must be noted that ARDS is not a specific disease. Instead, it's a type of severe acute lung dysfunction that is associated with a variety of diseases such as pneumonia, shock, sepsis, and trauma. The second cause is mechanical failure. Mechanical failure often arises from chest wall trauma. For example, a fierce strike after football game or a severe traffic accident. And in these patients, multiple rib fracture can be usually seen in their chest X-ray. In addition, pain and weakness after surgery and anesthesia are also very common reasons. For example, lung cancer or esophageal carcinoma resection. At last, long-term bedridden in elderly patients need more attention, especially in aging of population today. These are interesting pictures. Reflect the history of thoracic surgery, from thoracotomy to video-assisted thoracic surgery. Today, in China, minimally invasive thoracic surgery, we also call VATS, has been widely developed and applied in thoracic surgery. Traditionally, just as we can see in the first picture, thoracotomy was performed with a 20 to 30 centimeters post-lateral incision. Sometimes, one or two ribs was cut to get a better surgical view. But now, VATS is performed with 2 to 3 small pores. Each incision is only 1 to 3 centimeters length, and rib dissection is not required. Advance in technology have greatly benefited patients. In the past, it usually takes about 2 weeks for patients to leave hospital after the operation. But now, post-operative hospital stay is usually shortened to 3 to 5 days for patients with VATS. Atelectasis is also a common cause of ARDS, usually secondary to long-term bedridden or prolonged immobilization. Atelectasis means localized collapse of alveoli, and the problem is usually full-blown within a few hours after the initiating events. Only mechanical failure, aspiration, cardiogenic pulmonary edema, and pulmonary embolism can produce equivalent levels of hypoxemia so soon. The diagnosis is supported by auscultation of bronchial breath sounds at different portions of the lung, and occasionally, if severe cough is severe enough, by X-ray confirmation of plate-like collapse of pulmonary parenchyma. The most reliable confirmation of the diagnosis, however, comes with response to therapy, which can include encouragement of deep breathing and coughing. And sometimes we can also use bronchoscopy to suck sputum to reinflate the lungs. If all the above treatment doesn't work, mechanical ventilation should be used to treat the patient. Antidialysis should respond within a few hours. No other form of pulmonary insufficiency respond as quickly. Aspiration is also a very common cause of severe acute lung injury in surgical patients. It can occur in any patient who can't protect the airway. For example, one who has been injured or a dysesthesia. It's very common in infants and elderly. And the most common inhalation are gastric content and blood. Gastric acid or particulate matter in the airways leads to disruption of the alveolar and microvascular membranes, causing interstitial and alveolar edema. The resultant hypoxemia is usually evident within a few hours and is associated with a localized infiltrate on chest X-ray. The recovery of gastric content by suctioning from the endotracheal tree confirms the diagnosis. And the common site for aspiration are lower lobes in both sides. Pulmonary embolism is also a very common cause. Sudden deterioration of pulmonary function 5 days or more after an event such as operation, injury, or the beginning of immobilization that can stimulate deposition of clot in a large systemic vein should suggest the possibility of pulmonary embolism. Patients with cancer are at particular high risk, and in any patient, the magnitude of operation or injury and the great chance of venous thrombosis and embolization. The chest film is usually non-specific. Definite diagnosis can on rare oxidation be made by a radionuclide perfusion scheme, but this approach can only be successful in the face of a completely normal chest X-ray, an unusual occurrence after a major procedure. High definition enhanced pulmonary CT can sometimes make the diagnosis but carry the risk associated with transfer to the radiography suite and the use of large amounts of radiographic contrast material. And the pulmonary arteriography carries the same risks. And in many big hospitals, pulmonary angiography is necessary for diagnosis in most surgical patients. Pulmonary contusion is similar to mechanical failure, which arises from direct trauma to the chest wall and underlying non-parenchyma. Hypoxemia associated with localized infiltrations on chest X-ray develops over 24 hours as the injured lung becomes edematous. Pneumonia can arise primarily or secondary to aspiration, pulmonary contusion, or ARDS, and the diagnosis depends on bacteria and purulent material from endotracheal tree, hypoxemia, signs of systemic sepsis, and a localized infiltration of chest X-ray or CT. Different from the other types, cardiogenic pulmonary edema arises from heart and microvascular disease. For example, patients with high left arterial and pulmonary microvascular hydrostatic pressures, an acute myocardial infarction, or acute valvular disease. It's very common in cardiovascular division, and in many cases, cardiogenic pulmonary edema is excluded from acute lung injury. And the last cause is neurogenic pulmonary edema. Neurogenic pulmonary edema is associated both experimentally and clinical with head injury and increased intracranial pressure. The exact mechanism by which this occurs is unknown, but it's probably related to sympathetic discharge with post-microvascular vasoconstriction in the lungs and a resultant increase in pulmonary microvascular hydrostatic pressure. This form of pulmonary edema and oxygenation defect is rare, so other causes should be considered in patients with head injury.